On the positive side, and there is a lot to talk about on the positive side, it's good that we see such increased funding and heightened political will and recognition of health as a human right, which are indispensable elements of the desperately needed recalibrated global effort to tackle the pandemic of AIDS and our other health crises. So I think there is real progress. The work of the Global Fund in the fight on HIV and AIDS, TB and malaria. There was a recent committing to the Global Fund which didn't reach the full targets, but at least is very dramatic. And the PEPFAR commitment in this country has been very significant. So we're starting to see a significant impact of larger sums of money. The easiest way to measure this is in relation to antiretrovirals, the ARVs. 2.5 million people are now accessing ARVs, and that's up from a mere 100,000 in the year 2001. But 4.5 million people are still in need of ARVs. And in 2001, you may recall, very few governments supported the idea of universal access to treatment. It was Brazil and some countries in Latin America that were leading the way in developing countries. It's good that there are decreasing levels of infection in East Africa, with possibly the exception of Uganda, for ideological reasons. And this country bears some responsibility for those ideological reasons. A high ideology which is impacting on President Museveni, and the progress being made is now going backwards a little bit. But much more needs to be done for prevention, because as 6 people, as I understand it, are infected in East Africa for every 1 person who starts ARV treatment. This pattern will cause unsustainable treatment costs. While access to treatment must be accelerated, there really is an urgent need for prevention programs to have larger scopes and to produce large-scale results, and not to be ideologically driven from a sort of, a harmful, well-intentioned maybe, but not appropriate approach. I come from a very significantly Catholic country. I grew up in the Catholic West of Ireland. I am Catholic. I see now how the ideology is killing in the places where I visit. So let's get real and let's tackle that and have a more sensible conversation and stop this ideologically driven, largely as I can see it, certainly on television, by men. It's men who keep driving the ideological policy, and it's not to be, I don't know, it's just, it doesn't work. There's also an increased recognition that we need to tackle the drivers of the epidemic, which include gender inequalities, and which must be brought under control, particularly with attention to the underlying societal drivers of behaviour, which I've been talking about. The longer-term strategies for treatment cost are needed. And it's an interesting point that the Neagles G8 meeting in 2005 made a huge commitment to the importance of those, of the way in which the developed world would drive. And again, I want to quote Peter Piot, and I'm coming to the end of my contribution. But Peter said recently in a speech in Washington, he said, "At the 2005 G8 summit at Gleneagles, the leaders of the most powerful economies of the world made a commitment that was incredibly bold: to come as close as possible, as the text said, to universal access to HIV prevention, treatment, care and support. This was further agreed by the General Assembly of the United Nations, and this is really our ultimate goal. We cannot rest until the last person living with HIV has access to treatment. We cannot rest until reaching everybody with prevention activities and transmission is stopped. This is a crucial mission, but today we're not on track to achieve this. At the current pace, there will be fewer than 5 million people on treatment by 2010, just over half of the people who will need it. And when you look at coverage of mother-to-child transmission prevention programs, they are very, very, very low in many countries. So we have a big challenge. And in a way, so far, the history of the world's response to the global AIDS pandemic is littered with well-meaning but ineffective initiatives because of duplication, fragmentation, and lack of local understanding in the countries where we're trying to make a difference. So going forward, international institutions, foundations, bilaterals, private sector companies, non-governmental organizations, universities, and local players must, and as much as possible, complement each other and coordinate with each other. And here, I think the private sector in the 21st century is vital. And it's very good to see the private sector so well represented here. I've had an insight as a member of the Gavi Fund Board to how effective the private sector initiative can be. The Gates money and the private sector participants, experts on financial management, the IFIM, the new money for immunizing children. We created a market for immunizing the poorest children in the world. Let's create a market in some way for making sure that the poorest in the most rural areas who have this virus have access to what they need, because their countries need it, their communities need it, the world needs a safer world. That's our challenge. We have the evidence, we have a capacity to mobilize, we have a lot of work to do, and I'm glad that the Aspen Institute is giving some leadership on this. Thank you very much for your attention. Thank you.
In fact, much has been accomplished in prevention. In the United States, the prevention of HIV was somewhat a touchy subject. This is a picture of an old and dear friend of mine who's over 90 years old, who was our Surgeon General during the beginning of the HIV epidemic, Charles Everett, otherwise known as Chick Coop. And this is a picture of Chick in the Humphrey Building in Washington, D.C. He was a pediatric surgeon who was given the task of informing the American public in a somewhat conservative, if not puritanical, society when we talk about sex in this country. So he and I had a lot of very, very extensive talks about HIV because he's a surgeon, he didn't know anything about HIV. He made the decision that he was going to go out and talk the truth to the American people. So we put together a Surgeon General's report as well as a letter to every person in this country. That didn't make a lot of people happy because when you talk about HIV, you have to talk about sex, anal sex, oral sex, vaginal sex, injection drug use, gay men, crime, everything. So in the United States early on, we had a trouble with prevention. In fact, this cartoon says it very well. This is a woman going out and telling her children, if anything comes in the mail from the Surgeon General, don't open it. And that was the situation in the very early 80s. But in fact, we now know that there are many approaches to prevention. And the one thing that we've learned is that one size does not fit all, and there is no one type of prevention that works for everyone. I don't want to go through each and every one of these, but many of them have been proven to be quite effective. What is the problem? And it has to do with the challenges we face. If you look at the preventive measures that have been proven to be effective, and you match that against the people who have access to those prevention measures, again, it is somewhat embarrassing. Here, for example, injection drug users, only 8% of them have harm reduction available to them. 9% of the people who would benefit from condoms have it available to them. 9% of behavioral change programs for men who have sex with men are available to people in that risk group, and on and on and on. So we are challenged with having proven modalities of prevention